We're going to look at popliteal sciatic block for this session. Again, I'm going to use a high frequency linear probe. The patient is, here we have got a model here, Carly. So he's kindly agreed to do this session with us, and he's positioned prone. So you could do this block both prone, lateral, or supine. So here, for the sake of this demonstration, we're going to do the prone positioning. So he's positioned prone, and I've got a kind of linear frequency probe. And I'm going to orient myself, which is lateral, which is medial. So the left side of the screen is lateral, and the right side of the screen is medial. So you place the probe totally perpendicular in the middle of the popliteal fossa. And what I'm looking there is some kind of a vascular structure and nerve sitting on top. Again, there is a lot of anisotropy because of the way this popliteal fossa dips down and then rises up. So generally speaking, if you tilt your probe towards the feet, you get a better visualization of the nerve because of the anisotropy. The ultrasound beam has to be exactly perpendicular to the nerve. So what are the key landmarks here? I'm going to, generally the popliteal sciatic nerve is on the lateral side of the popliteal fossa. So I'm placing my probe on the lateral side. I'm looking for the popliteal artery, which is this big circular structure. The vein is a collapsible structure, as you can see from the screen. As I press hard, the vein completely collapses. And as I release it, it just kind of comes up again. On top of the vein is the sciatic nerve. It is very, very close there at that point. Now the next step you need to do is just to kind of trace the nerve proximally and distally to find out whether that is actually the full sciatic nerve or is it just the one component of it. So I'm going to trace it. So you see that now there's two nerves there, both sitting next to each other. As I go distally, they kind of separate away from each other. The one that goes away from the popliteal vessels or the common peroneal nerve, the one that stays with the popliteal vessel is the tibial nerve. So I just go back to the point where it bifurcates, and if I move his feet, just let me have some more chill. So if I move his feet up and down, so just let me relax, I'll do it for you. So if I just kind of lift it up, down, so you kind of see this kind of seesaw movement of both these nerves kind of rubbing against each other. So the idea is to kind of find the bifurcation and do the block at the level of the bifurcation. So if you're doing it in prone position, so you place the nerve at the level of the bifurcation. So because your end point is to get in between the two nerves inside the paraneural sheath. So I'm going to come from the lateral side. You see where my finger is pushing against the biceps muscle. So I'm going to come through the biceps muscle, totally perpendicular. So you will see a straight line of the needle coming through and getting in between the two nerves to block them. Some key points to note: if you're not seeing it straight away, do a little bit of a tilting motion just to see whether it shows up as bright echogenic structures. And usually you see the biceps muscle on top, the long and short head of the biceps, and on the medial side you will have the semimembranosus and the semitendinosus muscle. So in between them, just sandwiched between these two group of muscles, you will see the nerve. You always look for the popliteal vessels. You need to know exactly where they are before you do this block, so you don't want to accidentally inject intravenously into the popliteal vein. So that's the key points for this nerve. So we're going to move on to the ankle blocks. So Curly, do you mind turning on your back? So we're going to look at the ankle blocks now. So the main nerve to block in the ankle nerves is the posterior tibial nerve. That can be identified just medial to the medial malleolus. Again, probe orientation. The left side of the screen is anterior and the right side is posterior. So I'm going to slide my probe at the level of the medial malleolus. I'm just going to look for the kind of lots of tendons there. You see this bright echogenic things which appear like nerve, but they're actually the the tendons, and then you see the posterior tibial artery and a couple of veins around it. So if you scan behind the kind of posterior tibial vessel, then you see like kind of a triangular structure there sitting. You can trace them both proximal, distally. It's got a very wide echogenic architecture. As you scan proximally, you can see it is going next to the posterior tibial vessels. So I'm going to find a clear fascial demarcation around the nerve. So when I'm happy with that, so you see that triangular structure. So I'm going to target, like I do an out of plane approach, targeting the pointed end of, see my finger pressing. So I choose my entry point there. So I'm going to aim for that tip of the triangle, so that you're not injecting intraneurally, but at the same time you're not trying to target the base of the triangle where it could be going straight to your posterior tibial vessels. So you're trying to aim for the tip of the triangle. And because it is enclosed within the fascial layer, the local anesthetic spreads very nicely, and you need about 5 to 10 mils of local anesthetic to block this. You see, this is as big, almost 2/3 the size of the sciatic nerve, because this is the main component of the sciatic nerve, and it supplies the whole of the sole of the foot, all the osteotomes. So this is a very important nerve to block for foot surgery. Okay, so moving on from the medial side, you come to the anterior side. So the next nerve you're looking for is, so we're doing all these blocks above the level of the above the level of the malleolus. So you do the posterior tibial, then we're going to go for the deep peroneal nerve. So there you place your probe exactly on the tibia. So you look for the clear tibial outline there. So you see the bone nicely. On top of it is your dorsalis pedis artery, which is very nicely pulsating. And on the side of the artery, you have the deep peroneal nerve. So if I just kind of trace this artery up, you see that nerve is trying to climb over. So I'm just going to keep it like that. So just kind of climb over the artery. So I'll do this very slowly again at the nice tilt. So I see that it is trying to climb over it. And just kind of slides over the artery and comes to one side. Yeah? See, it's just trying to climb over and come to the other side. So you could block it on either side of the artery, and you will get a nice local anesthetic spread. Again, 2 to 3 mils is enough. It's a very small nerve. You see, compared to the posterior tibial we saw earlier, this is a very tiny nerve. And you have to make sure you're not injecting under the periosteum. So you have to, if you hit the bone, just withdraw the needle, and you just have to gently inject 2 to 3 mils. So the next nerve, as you move further, is that, if I ask Carly, can you bend your knee? Is that because the next nerve is a sural nerve. It is behind the lateral malleolus. So it is useful to have the foot resting down so you can access the saphenous nerve clearly. So here again, you see I'm going above the lateral malleolus, but more posteriorly. See, the left of the screen is more posterior, and the right of the screen, where I'm pressing my finger, is anterior. And you see like the little kind of behind between the tendon Achilles and the muscle here in the front. So you have a little hammock, and in this hammock lies the sural nerve. The sural nerve lies alongside the short saphenous vein. So there's a clear fascial hammock there. Hammock is like kind of where you just kind of, when you swing between the trees, so that kind of the fascial lining is there, and what it has within that little pocket is your sural nerve and your short saphenous vein. So it's very easily can be blocked again with the out of plane technique. Just put 2 to 3 mils. So if you're holding a probe, so insert your needle there and inject 2 to 3 mils of local anesthetic. So you could move the probe thing away. So you're injecting it. So I'm putting my finger just on top of the nerve, and you just inject 2 to 3 mils. So 3 nerves done. Now the another nerve that we need to block is the superficial peroneal nerve. That supplies the whole of the dorsum of the foot. The posterior tibial supplies the sole, whereas the superficial peroneal nerve supplies the dorsum of the foot. The sural that we saw just now supplies just the lateral border and the fifth toe, The deep peroneal, which was the tiny one next to the dorsalis pedis, just the first cleft. So it's mainly useful for the first toe and the second toe surgery. So the superficial peroneal nerve, unlike the other nerves, you do them slightly higher up above the ankle. So on the lateral side. So again, orientation, left side is posterior and the right side is anterior. So you look for the fibula. The fibula is this bone there, which is very small, and the tibia is this big bone there on either side. So if you look at the fibula, where the fibula ends, that's where it kind of draws up that fascial line, kind of draws up to where your superficial peroneal nerve is. So if you carefully look in the groove of the muscles between the two, see, I'm going to go all the way down where the fibula ends. Okay, so you see the pointed end of the fibula. The pointed end of the fibula is going to point at where the superficial peroneal nerve is. If I keep tracking it proximally and follow that groove, you will see that the superficial peroneal nerve lies in that groove, and at some point you will see it very nicely. Okay, so there. Okay, so there is the best place to block. So usually it accompanies by a little vessel. You see that pulsating there in that groove? So you just track it down when you can see the nerve clearly. Again, this can be done with an out of plane technique. So in this case, so you could do it from above or below the probe. So I see where my finger is. Yeah, where my finger is pressing. So that is where the superficial peroneal nerves. Again, 2 to 3 mils is enough. So we have seen 4 nerves, and these are the 4 main nerves that supply the forefoot. If you really want to cover the other nerve, which supplies a little bit of the medial malleolus area, then that's the saphenous nerve. It accompanies the long saphenous vein. So if you identify the long saphenous vein, then you can see the nerve. So we're going to look for the long saphenous vein. You see that big vein there, just over the tibia. So on either side, you see some kind of a nerve-like structure. It's very difficult to see in some. I think in him it is very clear and easily collapsible. So a simple perivenous infiltration around there. So you could do it in plane because there's no tendons there. You see this? If you approach the needle from there and you just enter into the pocket where the long saphenous vein is, then you can do a perivenous infiltration that will cover the saphenous nerve. This is just to make it totally complete. You don't need to do all 5 blocks for surgery depending on the location. If it's a big toe surgery, then you need to do 3, and if it is 3 for 3 toes or all 5 toes, then you may have to block all of them. So that is in a sense the ankle block. Both have different indications. Ankle blocks are generally done for forefoot surgery, whereas popliteal sciatic block for any surgery below the leg, the lower leg, ankle, and foot as well.